Hi, my name is Dr. Ross Hauser. Welcome to the Hauser Neck Center, Caring Medical in Fort Myers, Florida. Thank you for watching. Today's topic, we're going to talk about the three most common sequelae or consequences of ligamentous hip instability. And they are snapping hip syndrome, which is where there's a clicking, grinding, crunching sound that you can actually feel, sometimes you can hear. Hip impingement is where when you start losing motion, especially internal rotation of the hip, and that can be really, really painful. And then, of course, hip osteoarthritis. You guys see it all the time when you're walking around outside. You see people waddling. If you ever see somebody when they're walking and they're waddling, they have hip osteoarthritis. And then the waddling is because one of the muscles, the gluteus medius muscle, isn't holding the pelvis level. Now, ligamentous hip instability just means that the ligaments become incompetent or dysfunctional. The ligaments, the iliofemoral, ischiofemoral, and then pubofemoral ligaments in the front of the hip, they can't restrain or keep the ball part in the socket. So what happens is when these ligaments get injured, they get dysfunctional. The muscles then have to grab, and eventually if the muscles get too tight, that's where you're going to get that clicking, popping, grinding sound of hip, snapping hip syndrome. And then if the bones are moving too much, which occurs in ligamentous hip instability, of course, the forces on the hip, the socket portion and the ball portion increase, and then of course the body starts overgrowing bone, and that's what eventually leads to hip impingement syndrome and leads to hip osteoarthritis. Ligamentous hip instability causes a lot of things: iliotibial band syndrome, labral tears, right? Think about somebody whose MRI says that they have a labral tear and the doctor's going to go in there to do a surgery. Well, the thought process isn't correct. Like, if you have an injury that tears something, it's probable there's other structures in the joint that are also torn. So to me, a better option is do prolotherapy with or without PRP, and you treat the labral tear. You could treat the attachments of the iliotibial band. You could treat the tendons, the ligaments, the joint capsule. So to me, it's a lot more comprehensive and makes a lot more sense. You know, a surgery for one specific thing like a tendon or a labrum or a meniscus, it never made sense to me because those injuries are generally secondary. So labral tear is secondary to the bones moving too much because of ligamentous issues. The ligaments surround the whole joint. So this is going to provide a lot more stability if these are tight and strong than the labrum. Now, the three conditions that I want to emphasize today is snapping hip syndrome, femoral acetabular impingement, and then of course bone spurs or osteoarthritis. Then I have this slide on there to make the point that the more unstable a joint is, the less amount of force or the least amount of force it is necessary on the joint to have a severe symptom. Like when a joint's stable, like Dr. Hauser, my joints have been stable. So I can do these endurance events for hours and hours and I don't have hip pain. But if you have Ehlers-Danlos syndrome, and they've shown that if you have ligamentous laxity all over your body, your hip ligaments, your hip capsule is much thinner, like it's 50% less thick than, say, me. So you can just do a little bit of activity, like I'm going to go for a walk for a mile, and your hip hurts. So the more unstable the hip is, the more the ligaments are dysfunctional and incompetent. It can't handle the forces on it, the less amount of activity. Like here it says awful symptoms with little or no activity, severe symptoms with just a little bit of activity. So the more unstable it is, the more symptoms there are and the less amount of force that occurs. Now, this just kind of shows, you could see that this is the gluteus medius. So the gluteus medius, so when this contracts, it's going to pull the pelvis down. It's going to pull the pelvis down. So if somebody's lurching, it means that that muscle's not working so good. So if you can't stand on one leg, you can't stand on one leg and keep your pelvis level, and your pelvis goes like you lurch when you stand on one leg, that's called Trendelenburg's sign, and that's a sign that the gluteus medius is weakened. So it's probable you have either a pelvic problem or you have a hip problem. The other thing that's interesting with here, see how you see the iliopsoas muscle? So snapping hip, if you have the bones moving too much here, the iliopsoas can snap against the hip joint. Also, there's the iliotibial band that can snap over here. All these things can make a clicking or a popping or grinding sound. Here's the piriformis muscle, the sciatic nerve sometimes gets pinched in that, so hip instability can even cause sciatica. And then this is just kind of an illustration for it. So this is the iliopsoas muscle. You can see there's iliofemoral hip instability. There's a snapping sensation here as a person flexes the hip, and then you can even feel it. Like you could do this at home laying on the bed, lift your leg up, put your leg to the side, and you feel, is there a clicking, popping, grinding sound? If there is, you have a loose hip. And physical therapy is going to decrease the symptoms somewhat, but it's not going to be curative in a lot of patients because it doesn't address the ligaments. Muscles can get stronger with exercise. Ligaments, you have to stimulate them directly in the treatment. To stimulate a ligament directly to get it thicker, stronger, tighter is prolotherapy. So some people that go to an orthopedic surgeon, they say the bursa, you have a bursitis. Well, what causes bursitis is the hip joints moving too much, the muscles tighten, it irritates the fluid-filled sac. That's what a bursa is, fluid-filled sac between the bone and a tendon or muscle, so there's less friction, right? It's like in a car, you have oil. What's the oil there for? The friction between the metal surfaces is much, much less with the oil, so they can glide. So that's what kind of like the bursa does. It lets this glide over the bone here, and then it gets inflamed or there's more fluid in it when the hip joint is unstable. And then there's lots of different snapping hips. So there's snapping hip with the iliopsoas, snapping hip with the iliotibial, and there's snapping hips with some of the other gluteal muscles. So that basically, but the cause of it is, in my opinion, it's ligamentous hip instability. It's hip instability from the ligaments. This is, again, just shows that certain motions, depending on what tendon is tight or irritated, causing the snapping hip. Again, sometimes it's when the person abducts the hip, sometimes it's with flexion, sometimes it's with external rotation. Now this might be the most important slide in this presentation. If you have a chronic hip problem, snapping hip, hip pain, groin pain, right? That's normally when there's groin pain, you gotta think, well, you probably have a hip problem. And x-rays, they'll show some bony changes, but this is related to the bone moving too much. So a much better scan, which I'll show you, is a motion x-ray. But there's basically 5 joints that are involved in the lumbopelvic hip complex. So each of these affects the other. Like I showed you the gluteus medius, so that goes from the greater trochanter to here. So obviously, if let's say there's sacroiliac ligament problem and this bone is moving too much, that's going to affect the tension in the gluteus medius muscle. So a person might say, hey doc, I got like pain on the side here. You know, like I got buttock pain or something like that. And it may be related to the hip, but also might be related to the sacroiliac joint. There's basically 5 joints that are in the lumbopelvic hip complex. The lumbar joints, which the lumbar vertebrae connect at, structures, which are the joints called the facet joints. Whenever you hear Danielle or I talk about facet joints, That's the joint that moves the spine. The joint that moves the spine is the facet joints. And what holds the facet joints together are called the capsular ligaments. So when somebody has neck pain, thoracic pain, low back pain, it almost always is the facet joints. Then there's the lumbosacral junction. So that's the connection between the lumbar vertebrae, especially L5, and the sacrum. Then there's these big sacroiliac joints that connect the sacrum to the innominate bone. And those are notorious for causing low back pain that's on the side. Real low back pain, but it's on the side. Disc pain is almost always central. It's right in the middle. But almost every person that comes in with low back pain, it's almost always on the side. That's the sacroiliac joint. Now you might say, come on, doc, I thought you were talking about snapping hip, impingement, osteoarthritis. Well, let me ask you this. What's the socket portion of the hip joint? The socket portion of the hip joint is in the innominate bone, the iliac bone. Well, what are the joints of the iliac bone? Well, it's the sacroiliac joint in the back and the pubic symphysis in the front. Pubic symphysis in the front. So what's going to happen if this is unstable? The innominate bone's going to turn, and then all of a sudden you have impingement, like just a turning of the innominate bone, 2 millimeters, 3 millimeters can actually cause impingement where the ball portion of the hip joint can't move normally, and all of a sudden you have reduced motion. So the easiest way to tell whether a person has like hip osteoarthritis, impingement syndrome, even hip dysplasia, where the socket portion, the ball portion, is not normal. Like, where somebody might have a shallow socket or too deep of a socket, or the bone, they're born with misshapen bone. So you'll get to see my motion. I have very abnormal motion because of hip dysplasia, which I was born with. But the reason why I never had pain or a disability is why? Because I've had a stable hip. So just because the doctor says you have hip dysplasia doesn't mean you got to get an operation. You might just need some prolotherapy to stabilize it, because I think the symptomatology in a lot of times with somebody with hip dysplasia is just that they have hip instability. So, and then of course we have the hip joints here. So when assessing somebody with a symptom in any, that could be from any of these joints, you got to look at the other joints because they're interconnected. So here, so we do motion x-rays. You could see, so we can have a person move, so this person's moving the hip joint to the side, and we're seeing the hip joint here. So say you had the ball in the socket and they're moving it, and then all of a sudden it goes out or it goes in where you see a separation, like you see a separation. In this particular patient, if you look really closely, you're going to see that this expands right here. It expands right here. So we can stop it, we can measure it, we can tell, a person has a 3 millimeter subluxation of their hip. And this particular patient, had some clicking, popping, grinding in their hip, and they've already started prolotherapy for it. What's really neat too is you see the pubic symphysis here. You can see it's a little bit crooked. So that's a sign that we know that there's some pubic symphysis instability. And if you look really closely here, when the person moves, you can even see their sacroiliac joints change a little bit. So again, it's much more than just do prolotherapy there. It's do prolotherapy in the other body parts too. You can tell somebody's 3D anatomy, so we can measure the top of the iliac crest to the ischial tuberosity. You can see, are the femur heights the same? Is there an apparent leg length discrepancy or short leg that really isn't there? Like the femur bone and the tibial bone actually are the same length on both sides, but there's apparent leg length discrepancy because one innominate bone is misaligned or it's rotated anteriorly. So one of the things that we do is, not in everybody, but in a lot of people, we do a Gonstead measurements just to see the 3D anatomy, and that helps us determine somebody needs physical therapy, somebody needs exercises, somebody needs a heel lift, somebody needs prolotherapy in a certain spot, somebody might need mobilization, like maybe the sacroiliac joint is fixed on one side. So that's one of the things that we do. And then when thinking about what does ligamentous hip instability cause? Like, how does impingement or the overgrowth of bone occur? Well, when there's excessive pressure on the joint, and the excessive pressure on a joint is because of excessive motion. So what causes the excessive motion is ligament injury, because the ligaments are the ones that limit the motion. So when the ligaments are tight, the bones just move in the normal amount. But if the ligaments are incompetent, the bones move excessively, and eventually excessive pressure occurs. So if excessive pressure occurs on a bone, on a bone, on a bone, what do you think is going to happen? Well, the bone's going to overgrow. The bone's going to try to accommodate that extra pressure by overgrowing the bone to limit the motion, but also the more bone there, the more the forces will be diffuse, right? So if there's a pressure on a really little area, well, that area is going to break down. But if the pressure is over a larger area, the forces go down, and there's less chance of micro or cellular damage, and macro is where there's tissue damage. You might say, well, what do you mean tissue damage? Well, eventually there's going to be tendinopathy. The gluteal tendons, the iliopsoas tendon will get degenerated. The cells will die because of the increased pressure. And then obviously a weakened tendon or degenerate tendon is more likely to tear. So the cause of that typically is underlying ligament injury. And then eventually you're going to get the cartilage is going to start cracking, and you're going to end up getting where the cartilage wears out. And then once that happens, the motion of the hip joint is altered a lot. And that's where somebody starts waddling because they're not moving the hip joint normally. Do you realize every year, every joint of your body is moved 1 million to 2 million times? And you might say, well, God, that's a lot of times. So people are like, oh, I didn't do anything and now my hip's killing me. Well, no, you did do something. So if you're 35 years old, you've moved your hip joint 35 million times or 70 million times. And that motion is necessary for the synovial cells to make the fluid which cushions the joint, and that fluid, when you weight bear, the fluid is pushed into the cartilage. So that's one of the ways that your cartilage gets nourished. So if you stop moving, like, you can degenerate a whole joint just by not moving. Because why? Not because there's too much pressure, but because there's not enough pressure and the tissues aren't getting nourished. So you need to move the joint. So that's why I say probably for the lower extremity, the very best exercise probably is bicycle riding. Because bicycle riding is easy on the joint, even a stationary bicycle. Or some of my older patients, they'll just have those pedals, like they'll just have the pedals. And Izzy, who's filming this, like, I see her, she has some kind of pedal thing that she'll be working, and then she's moving and getting herself in better shape. So to me, that's a good exercise. Of course, swimming is very good also, and of course, walking. Walking is spectacular. So what actually is impingement? Well, impingement is that the hip joint can't move, the femoral head, the ball portion can't move normally and gets impinged or limited by either a pincher lesion, which is the socket portion, there's an overgrowth of bone, or the femoral head gets a bump. So we can see these bumps, the pincher bump or the cam bump, on x-ray or on our motion x-ray. So basically on motion x-ray you'd see these things colliding. So the treatment is, well, you would say, well, then doesn't it have to be shaved? Well, it's amazing, once you tighten all the ligaments, these things just typically don't bother you as much. You need so little hip motion to live a normal life. For walking, for sitting, for most of the activities we do, you just don't need a lot of hip motion to have a full life. Now, obviously, if you're an elite athlete, you need a lot more motion. So this is caused because this is moving too much. So if you have ligamentous injury, this is injury to the iliofemoral ligament, which is the most important ligament in the hip, then basically the ball part is going to move excessively, so eventually it's going to hit this, and then you get a pincher deformity, and then basically with internal rotation, you feel groin pain. So if you move your hip in and you're like, oh my gosh, that hurts a lot, you probably have some kind of impingement. And then hip dysplasia is kind of similar in that there's a mechanical problem, because that's really what impingement is. There's a mechanical problem between the ball and the socket. So hip dysplasia, that's what I have, is my ball part doesn't fit quite normally because there's dysplasia. Either the head, the femoral head is changed, or the hip joint is changed. So it doesn't fit quite so good. A typical patient, history of groin pain, the orthopedic surgeon had given some steroid shots. They eventually diagnosed them with hip impingement. They had a labral tear. The doctor was gonna do some surgery. And then a lot of times the hip labrum, they don't actually repair the labrum. They take out part of the labrum. Or even if they repair it, you would never want somebody to put something metal like staples or something into the joint, because again, think about this, before you sign up for surgery, you're going to have to move that thing 1 million to 2 million times every year. So if you just start thinking about that, you're like, no, I'd rather keep my body parts in there, my labrum in there. Why don't we just stimulate it to repair? That's what prolotherapy does, stimulate it to repair. So this particular patient received prolotherapy in the front, in the back. On physical exam, they had constant clunking sounds with the hip. So again, they had snapping hip with hip impingement. So they just needed 3 platelet-rich plasma. So platelet-rich plasma is where you take out some blood, spin the blood down, get the growth factors. So that was injected into not just the labrum, but also the ligaments. And basically, they were able to exercise without any pain. So, I just have this in here just to show you some of the parts where people have pain, but these are also the parts that are treated with prolotherapy. So you're doing the hip joint, you're doing the hip ligaments where the tendons attach, and then that's the muscle that gets weak in a lot of hip conditions, and that's why there's weakness in the hip, or there's waddling. So if you ever see somebody with a waddling gait, this is just a study in 2019. So it was treatment of osteoarthritis secondary to developmental dysplasia of the hip treated with prolotherapy versus exercise. Exercise does help. So you see the exercise here. This is the prolotherapy. This is a functional data. So the prolotherapy people had much better function. And then the pain level, exercise got them down from 7.4 to 4.5, prolotherapy 7.8 to 3.2. Then this is our data on over 90 hips. You could see before prolotherapy is here, and then after prolotherapy is the black. So you could see one was no pain. So you could see 70% of the people either had no pain or just a little bit of pain. And then we did a study with hip labral tears. So hip labral tears, the cure rate was 54%, and the pain level went from 7.5 to 1.3, which is very, very good. In our hip study on people who were told they needed a hip replacement, 100% of the people, and when I say needed a hip replacement, this was before they got prolotherapy, 100% of the people who came in with a pain level of a 10, like terrible, they got 50% pain relief or greater. So even if you've been told you need a surgery, I always think it's good to get a second opinion from a doctor that does conservative care. So ligamentous hip instability is the cause, in my opinion, of snapping hip syndrome, hip impingement, and hip osteoarthritis, and a really good treatment option is prolotherapy.